Hello, welcome to this online event hosted by the Bennett Institute for Public Policy at the University of Cambridge. The event is titled The Great Vaccine Rollout, COVID-19, Cooperation and Global Public Goods. The Bennett Institute is committed to interdisciplinary academic and policy research into the major challenges facing the world and to high quality teaching of the knowledge and skills required for public service. My name is Flavio Toxvaerd. I'm a university associate professor at the Faculty of Economics and the Fellow of Clare College here in Cambridge. And my research over the past years has been on the economics and policy of infectious diseases and epidemics. So as you can appreciate, these have been a busy few months and last years. This is an epidemic, of course, that has changed our lives in profound ways, not just economic, but also in terms of health and in terms of society more generally. And so this is a good opportunity for us to take stock of the experience so far, both in terms of the development of the disease, but also in terms of our policy response to this disease. And not only to take stock, but also maybe to look to the future and to see what lessons have been learned and how we can do things better going forward. Now, before I introduce today's speakers, I would like to just give you a few housekeeping notes. First of all, the broadcast will have available closed captioning in case you need that, and you can turn those on yourself by using the button at the bottom of your Zoom screen. Second, as part of the event, there will be opportunity for participants to ask questions either to the entire panel or to specific speakers. Please use our chat function for that purpose. Start by stating your name, affiliation, and organization if relevant, and also please state whether this is for a specific person or whether it's just a general question, and then I will collect these, and at the end of the event, I will pose as many of these as I can to our speakers. And last, if you wish to tweet about the event while it is ongoing, you can use the Twitter handle #VaccineRollout. Further details will be given in the chat. Without further ado, let me introduce to this evening's speakers. Jessica Metcalf is an associate professor in ecology, evolution, and public affairs at Princeton University. She is a demographer with a broad interest in evolutionary ecology, infectious disease dynamics, and public policy. She works on an array of health questions with a particular focus on vaccination policy, combining public health surveillance data with novel data sources, including mobile phone call data records and mechanistic models of infectious disease spread to characterize the intersection between human demography, behavior, and infectious diseases. So welcome. Second, we have Scott Barrett, who is the Lenfest Earth Institute Professor of Natural Resource Economics at Columbia in New York, with appointments also in the School of International and Public Affairs and the Earth Institute. And he is also, in fact, the Vice Dean of SEPA. Scott is a leading scholar on transnational and global challenges ranging from climate change to disease eradication, and his research focuses on how institutions like customary law and treaties can be used to promote international cooperation. And last but not least, Ramanan Laxminarayan is a founder and director of the Center for Disease Dynamics, Economics and Policy that has a presence both in Washington, DC and in New Delhi. And he is also a senior research scholar at Princeton with a number of further affiliations. And since 1995, he has worked to improve the understanding, especially of antimicrobial resistance, which is, of course, an increasing problem and has since the start of the epidemic been particularly busy informing both policymakers and the public about how we should understand infection policy. And I have particularly, benefited from his untangling of the Indian experience. And I should also maybe say that Jessica and Ramanan are the only two people on this panel who have TED Talks, and that just shows what kind of reach these speakers have. Okay, having said that, let me now turn to our guest speakers, and I'd like each guest to maybe take about 5 or 6 minutes to talk to us about their work and their engagement since the start of the epidemic from their methodological or rather kind of policy perspective. And please, could I ask Jessica to start us off?
Well, thanks very much, and thank you so much for having me. My expertise is very much as a biologist. So I've been using what we know about the mechanisms of infection of individuals and how infections spread across populations to try and understand what the consequences are of countries choosing to share or not to share vaccine doses. At the first level, of course, every vaccine dose that goes into an arm is a good thing because it reduces mortality and it reduces cases or severe infections. And it also, to some degree, reduces the rate of infection, although this is not perfect. But thinking at this epidemiological scale, one can see that if you can reach a stage where you've immunized a sufficient proportion of your population such that one infection causes one or less new infections, then it doesn't necessarily make sense to hoard doses. You should be sharing them perhaps simply ethically. But there are other reasons why you should be thinking deeply about sharing, and this is the evolutionary angle on the problem. So everybody on the planet, everybody in every country in the world is surely concerned about whether new variants will emerge, and they could be concerning because they are more transmissible, or because they're more virulent, so they cause worse disease, or because they can escape immunity. So our vaccines no longer work, or individuals who had previously been infected are more at risk. And what does this mean in terms of thinking about infection around the planet? If you just think in terms of how new variants can emerge, the more people are infected, the greater the risk of new variants arising. There are nuances that come in. So you might expect, for example, that greater levels of immunity in the population might increase selection or increase the advantage of variants that have the capacity to escape immunity. But it's worth remembering, one, that we don't know whether this is different in individuals who've been infected or individuals who've been vaccinated and acquired their immunity that way. And we also don't know the degree to which we've seen several times when variants have emerged, they've emerged in completely susceptible populations, for example. So that's at the population scale. At the individual scale, we can say something about what we expect for emergence of variants, but what we can say is very little. We can say that if you don't have any immunity at all, there's no advantage to a variant that can escape immunity. If you have complete immunity, then a mutation that can escape is not able to escape immunity, so won't be able to spread in the population. And so it's partially immunized individuals that might be where we'd expect novel variants to emerge and spread. So then, of course, the big question is we don't actually know what the shape of that distribution looks like, whether it's individuals who've been naturally infected and then their immunity has waned, whether it's individuals who've been vaccinated. There's still an awful lot of uncertainty, but what we can do is build models to think about what these futures might look like in different ways. And across a spectrum of models, it generally makes sense that to reduce the emergence of problematic variants, we would wish for a world in which there's the lowest number of infections possible, which is probably a world in which doses are shared. And so this is, I think, the angle which I came at this problem with.
Wonderful. Thank you very much, Jessica. Let me now turn to Scott. Scott, would you like to talk to us a bit about your experience?
Well, thank you so much, Flavio. So not only do I not have a TED Talk, so I'm the least impressive of the three, but also I was Vice Dean, Flavio, no longer. And I was Vice Dean during a number of crises. And unfortunately, that meant that I wasn't doing research on the topics I care the most about, including this one. So I'm just going to share some thoughts, though. And I'm glad that Jessica started off with that point, because actually that was one I wanted to come to, and I was going to acknowledge my own ignorance about that. So basically, I think, first of all, we should understand the context in which COVID emerged, and that's a world that has been pretty fractured. There was a movement towards nationalism, self-interest. There was a growing lack of trust. In fact, in some places, disdain shown for multilateral institutions. Not great background for dealing with a global crisis. So I think we just started off in the wrong place, as it were, for a problem like this. We had certain apparatus in place, like the international health regulations, which basically are the main legal arrangements for dealing with spread of infectious, emergence and spread of infectious diseases. These were grossly inadequate. I think that's very clear. Recommendations from the WHO were things like not having trade and travel restrictions were ignored. There remain problems of identifying the origins of SARS-CoV-2. There were issues of reporting, although I think reporting actually was better this time around than it was with SARS. So that's all the background. And of course, we had various dysfunctions within individual countries. I could spend some time talking about the dysfunction within the United States. But globally, focusing on the vaccine, I think that it does command our attention. And there's a long chain of things that have to happen for vaccine to be valuable to the world. First off, you have to develop the vaccine, and that requires some basic research underpinning this. And there was a lot of support given, public support for that and for development of vaccine. It would be interesting to find out whether that was handled well, in the sense of whether the right kinds of vaccines were developed, whether too much money was spent in the sense of too much going to the pharmaceutical companies relative to the returns that they're earning. I think these things remain unclear, at least to me. The thing about the R&D and the vaccine development, the richer country, basically when you look at the international system, the one thing you can pretty much rely on is the impulse of self-interest. It's very powerful. And it's fine for us to say that we should be emphasizing the ethical obligations that exist for helping others, but we also have to be aware of the power of that impulse. And it's not all bad, because I think that desire to advance self-interest accounts for the speed, remarkable speed for developing vaccines and making them available for some people. So I think obviously the distribution issue is huge, but it is remarkable that the world as a whole, I don't mean united, but as a whole, actually developed a number of vaccines that have been effective and did so quite quickly. So the world did well on that. On the manufacturing of vaccine and distribution, less well. And the richer countries did better, of course, because they had the wherewithal. They acted first, and they were able to command access. I think the problem with the global effort has been a weakness at this level primarily. So it's with manufacture and distribution. Now these issues, for the richer countries to be involved in a productive way, I mean, you're either going to rely on them to be, I'll use the word charitable, which I would promote. I'm not being discouraging about this, but again, self-interest is something to pay attention to. I think that Jessica's point is really important, because why would other countries want vaccine to be distributed worldwide? Well, one reason would be you want to continue commerce, you want the wheels of the global economy to turn, all these problems we've had with supply chains and so on. So it's clear that problems in some parts of the world create difficulties for other parts. So that interdependence actually should help promote efforts that can reduce transmission. I think another critical issue is whether continued ongoing transmission in developing countries could pose a risk to the efficacy of the vaccines. That was Jessica's point. I think that's really important. And as I looked at that as a amateur, I could see these two different sides to it. One, that you want to reduce infections and not reduce the case for variations, and the other, maybe there's a little bit of selection going on. So Jessica talked about that. I did a little reading just before the meeting, and I found work that was pretty encouraging on this, that the vaccines actually seem to help to dampen down variation. Now, if that's the case, then you clearly, that global reduction in transmission is a global public good. That means that the richer countries have this extra self-interest in wanting to ensure protection worldwide. That kind of information is very important. That kind of information can drive public policy. It also can help promote international cooperation. And that cooperation, again, is going to be needed for the manufacture of vaccine. And there's an issue, and I'm not the expert on this, about whether that requires ramping up capability to produce these mRNA vaccines versus having vaccines that could be produced using facilities that are available more widely worldwide. But however that works out, on the distribution side, there are also really big issues, and they really come down to development. So we're talking about local public goods more than global, and these two things are complementary. So having the global, in other words, having a vaccine is not of super great benefit to the world if there isn't that capability locally to distribute the vaccine and make sure that people are getting it. So these two things have to be coupled, and I think there's been a lot of emphasis on the vaccine development and manufacture, a little less on the distribution side. And we've seen this before. I looked years ago into the eradication of a disease called rinderpest, which is a cattle disease. And the World Bank was approached to be a partner in an effort to try to eradicate rinderpest. And the World Bank, believe it or not, said, we're not going to do that because we don't think there's the capability within these developing countries. This is in sub-Saharan Africa, basically the veterinary infrastructure to actually carry out the effort. And what's so wonderful about this example is that the effort went ahead anyway and succeeded. And you have to wonder, what is the purpose of the World Bank if not to provide for, we're talking about a relatively minimal infrastructure, by the way. I'm not talking about a whole health system. I'm talking about really one of the great things about vaccination is you don't need all that. You just need enough of an infrastructure to get, obviously there are issues with the cold chain, but then to get the vaccine into people. And the last thing I would say, all this, and this is a pervasive problem worldwide, a little greater in some places than others, but this reluctance of people to get vaccinated. It's an age-old thing. It's been around forever. I looked into inoculation in Britain in the 19th century. It was a big problem there. So this has been with us all along. But we are dealing with a world now that's very polarized. Certainly the United States is extremely polarized. There's a lack of trust in basic institutions, a lack of trust in science or a belief in science. I'm not sure what words to use. And this is holding back everyone. It's very corrosive. So again, I think that the background to all this was really unhelpful. And I think the experience so far has not been helpful in terms of how the world is leaning or predisposed to address a common threat like this. So I think the stakes here are really high, and they go beyond just this one pandemic, but also for the future of global health and other issues as well. Thank you.
Okay, thank you very much, Scott. Ramanan, could I direct the word to you?
Sure. Thanks, Flavio. Thanks for having me, and pleasure to be on with Jess and Scott. I think, Scott and Jess covered a lot of what I would want to say, which is, I think the first thing to acknowledge is that we are lucky to have a vaccine at all at this time. And we're very lucky to have more than one vaccine at this time, probably 5 or 6. And without this, the world would be in a very different place. I think just imagine a world where we had no vaccines by now, completely plausible, or we had maybe one vaccine that worked and that was in the hands of a country which was not really willing to share with anyone else. I think we probably averted a really nasty situation that could have emerged in that kind of a world. Fortunately, there are vaccines that are being manufactured in multiple countries around the world. Certainly, there's a huge inequity in that. Much of the African continent seems to be, seems to have not had the benefit of vaccines, and there are other parts of the world that haven't reached the coverage that they really, should reach by now. But at the same time, vaccinating 6 or 7 billion people on the planet is not a trivial task, and I think that as far as we've reached now is impressive. We should do and could do better, but we could have done a lot worse. So that's the first thing to really acknowledge. The second is, as Scott said, our barriers have not really been in terms of science, but rather in terms of policy. Was it possible? I mean, are these technical challenges that have prevented us from really getting the vaccines manufactured in larger quantities and getting it out in other countries? No. The mRNA vaccines are entirely possible to manufacture at much larger volumes than they have at this point in time. And, truth be told, if we had approached this with even sort of the seriousness that PEPFAR took on HIV, this would have been an opportunity for the United States to have launched an all-out effort around the world and led that effort in order to make sure that every country was vaccinated, using the US military if that's required, using all of the NATO apparatus that is required. That would have been a show of leadership, which unfortunately has been lacking, certainly from the previous administration, but sadly from this administration as well. It just confounds me why, in this moment of crisis, which would have been a chance to show leadership, and this could have been Biden's moment in many ways, he just has not showed it. And this is not just just the U.S. president. This is across Europe, most of the leaders there as well. So that's unfortunate. Certainly this has consequences again for how much trust these countries will place on the rich countries in terms of something happening in the future. And the answer is probably very little. Now, of course, they could choose to develop their own vaccines. They don't have the scientific apparatus to do so. They could manufacture, and maybe they will get into some of these. But certainly, I think there'll be a lot of rethink and realignment about how much one can really rely on international institutions in moments of crisis in the future. And I think, sadly, the answer is going to be that we can trust the scientists to develop stuff, but we can't trust these institutions to either tell us the truth or be able to respond in a significant way. Now that's possible. Of course, these countries have their own challenges, and perhaps they will do nothing, once COVID sort of fades away at some point. But certainly there will be at least some countries that think more carefully about their future investments in vaccines. Now, India is a specific example. India's had probably the largest epidemic in the world, has probably lost a few million lives to COVID, and well documented at this point in time. It's also the home or the birthplace of, so to speak, of the Delta variant. Not a surprise, because India does have a lot of people, so the chance for the virus to mutate and find variants that are fit for survival would happen in a place where transmission was relatively free. Again, the challenges of controlling COVID in India are not trivial. I think the scale of the effort that was finally mounted, for testing, for containment, have been impressive. Certainly, one could guess that one should do more, but we have to remember that you can't build a public health system in the middle of a crisis. And India fought COVID with the public health system which it had, which was not a very strong public health system. And I think India was lucky to have gotten away with just a few million deaths. I think the estimates are anywhere from about 3 to about 6 or 7 million deaths, much larger than the 500,000 deaths that have been reported by the government. But certainly anyone who understands the data knows that those numbers are vastly underreporting deaths and cases as well. Now, that's all the bad news, where it's been an unmitigated disaster, humanitarian disaster in India and in many other countries. But it's also a country that has done impressively well on vaccination coverage. Certainly one could argue that it could have done even better. But some of the biggest challenges to vaccine rollout in India have really been about manufacture of the vaccines. Many of the raw materials for vaccine manufacture were sort of cornered by countries that were going after them first. So even if you have a different vaccine, you need some of the same ingredients to fill up the vials and stabilize them and so forth. And those were all cornered by the West. And I think that once those supplies were released, the Serum Institute and Bharat Biotech have really stepped up, especially the Serum Institute. And India crossed 1 billion doses of vaccine just last week. One could argue that it should have gotten to 1 billion a while ago, but the fact remains that no other country has distributed 1 billion doses of vaccine. No other country has. And for a middle income country to get there with vaccines entirely manufactured within its boundaries is, I think, quite impressive. And I think other countries will be looking to India and saying, maybe we should make those investments in vaccines ourselves. And sadly, the lesson from COVID would be that global collective action is much more in Scott's books than it is in real life. And maybe we should we just can't depend on global collective action, in instances like this, and maybe that spills over into climate change as well. So I think there's good news here and bad news here, but at the end of the day, it's people will have to look at this with clear eyes and say, what can they really depend on, and what can they not depend on? Now, India, of course, has also been subject to criticism for having promised a lot of doses of vaccine into COVAX and not having delivered them. But by the same token, many of the developed countries didn't deliver either for COVAX. So to point fingers at this one country, which has a large population, and say you didn't deliver into COVAX, when I don't know, how much mRNA vaccine there is in COVAX is really a fair question to ask at all. And I think at the end of the day, you have to remember that national governments are first and foremost accountable to their own populations. That's why they're elected. They're not elected to send vaccines over the border. And, we might wish that to happen, but that's not going to happen in the way that the world governance is set up with nation states. And so unless we have a mechanism where it is in countries' self-interest, which is clear and visible to their populations to be able to share vaccines, I suspect that if we were to have a redux of something like COVID in the future, pretty much the same situation, the same sequence of events would play out, and there's no reason to expect that anything different would happen.
Thank you very much, Ramanan. As a matter of fact, my second AstraZeneca dose was produced in at the Serum Institute in India. For a moment, I thought I might not be able to travel because, of course, the European Medicines Agency did not deem those to be equivalent to the UK-produced ones. So I'm one of the beneficiaries of an Indian vaccine. Could I just ask the team to show the graphic that we? So just to kind of couch our discussion, this is a plot of GDP per capita of a number of countries, and on the x-axis, on the y-axis, we have total vaccinations per 100 people. And then this is just to hammer home the point that clearly income per capita is certainly part of the story to explain which are the countries that actually got to get the vaccine. Things have become better than they were in the beginning, but also in my own research with Chris Ault, we looked at whether countries that vaccinated the most were necessarily the ones that had the biggest need. And again, we could easily discard that idea. It is certainly not the people that had the worst outbreaks who vaccinated the most. So thank you very much. If you could just take that away. So Ramanan, if I'm understanding you correctly, what you're saying is that there could be two possible lessons drawn from what has happened. The one possible one, which is the optimistic one, is that everybody has seen what kind of car crash the international cooperation has been. And so this should really spur us on to do better next time. And the alternative is that people take the lesson that really it is important whether you physically control the vaccine process or production process, and therefore you would have more fragmented picture going forward where people become more self-sufficient. Now, in some sense, if the benchmark is that there is no coordination and no production anywhere, a situation where people produce on their own in different countries seems to be better kind of than the worst case scenario. Would you agree with that at least?
No, actually, I would not. I mean, the whole premise of COVAX was really that there would be 170 or 180 companies that were producing things. And COVAX was supposed to help the world collectively figure out the few companies where you could incentivize. Remember, the usual vaccine production process is you come up with a vaccine, you put it through clinical trials, and that's when you bet on whether to invest in the production facilities at all. That's usually the way in which it happens. What happened with COVID was, because of Operation Warp Speed and other investments that were made, the manufacturing capacity was put in place at the same time that the vaccine was being tested. Unprecedented, has never happened before. But that was because of specific investments made by specific countries. And and the previous administration in the United States, for all of their other challenges with dealing with COVID, did make a significant bet on doing exactly that, which ended up being quite an important investment to have made. So I think that the right way to do it is really with some sort of a coordinated approach where we are collectively as a world betting on a few manufacturers, because we can't set up manufacturing capabilities for 170 vaccines. We need to have the capability to figure out which ones we want to really bet on, and then invest in those production capabilities, and recognizing that a few of those might fail. Novavax, we thought it would be out much earlier. It's still not really out the gates yet. No one has a Novavax vaccine. So we need the scale that you need to make those bets are really at a global scale. But eventually the whole thing sort of didn't really pan out because the world just refused to play together. That's really what ended up failing COVAX. The West refused to really contribute into COVAX and be part of that process. And India had its own set of issues with vaccine exports. And the entire mechanism, I would say, has not performed that well, not because of a design flaw. The main design flaw in COVAX is really that it was betting on countries to rise above their very narrow self-interest, to recognize that variants emerging in other parts of the world would affect them. And as it happens, national governments just did not pay attention to that problem at all.
So what chance is there for changing the adherence to these commitments? Is this a matter of public engagement, naming and shaming, or what can we do?
Well, I think you should ask Scott that question, because he often talks about how getting global cooperation is very difficult and happens only very rarely. So maybe he'd be better placed to answer the question, and particularly, in the context of when there is also a national interest to just focus on yourself. And there are other examples, right? I mean, the case. I mean, I'll let Scott answer this, because there's actual structure to thinking about these problems.
Oh gosh. Okay. Now, any hard questions I get, Ramanan, I'm gonna have them, directed at you. First off, I really agree with Ramanan's sentiment that this was an opportunity for the United States to show global leadership. Gosh, my disappointments in the United States run pretty deep right now, and I just don't think we have a government or a population with a strong appetite for that right now. I'm sorry to say, I wish that weren't true, but I think that is true right now. It does remain the case, though, and I think it's different. Early in the when the vaccines were just rolling out and the capacity is heavily constrained, I think it's reasonable to expect countries to look after themselves first. I think that's reasonable. In fact, I think even other countries, to some extent, would recognize that if their tables were turned, they probably would behave in a similar way. I think once the vaccination rate is sufficiently high and the vaccines retain their efficacy, then the problem shifts, because now, relatively speaking, it may be what's going on elsewhere in the world starts to matter more, and the constraints at home become weaker. So I think it would have been natural to see a kind of progression. There could be leadership from one country. We're not seeing that. It is disappointing. I think it's a major failure, but we have supplied other public goods with truly collective action, and we have arrangements for how to finance these. Given that there probably is this, and this goes back to Jessica's comment, I think not entirely, because there's also the trade elements and so on, but I think it is a potent consideration that if vaccinating other populations offers more protections at home because of the reduced risk of variants emerging and spreading, then that's something that I think can be explained to populations. Now, that's a global public good. I think global financing would be reasonable. I think the COVAX, which I haven't studied as much as I'd like to, it seems like pretty amazing. It was stitched together so quickly, but its basic premise about trying to combine an incentive that rich countries would have to be part of a portfolio where that whole portfolio wouldn't be available to individual countries because it'd be too costly. And then the quid pro quo being that there would be distribution to poorer countries. The thing is that the richer countries can opt out of the part, and basically they can opt out de facto in the parts that aren't as self-serving. So I do think that the incentives change and that they're different now, and that there could be and should be a global effort to address these issues, not only of the manufacture, which is one critical issue, the distribution, including the capabilities within countries to make sure that the population gets vaccinated. That really does require, I think, today a global effort. And I think, if the World Bank, the IMF, even, if they want to maintain their own credibility for global development, I mean, this is really where they really need to step up in partnership with funding from the richer countries. I don't know where the global leadership is for that more complex effort, but I think that's where our attention should probably focus.
So maybe I could ask you, Jessica, a question in this context. So it seems to be the case, both from what Ramanan and Scott are saying, that rather than relying on people's goodwill, we might have to focus on some notion of enlightened self-interest that centers around this idea that if we don't do something, it's going to come back to bite us because it's going to evolve. Now, that's a hard sell if we don't have kind of way to quantify these things. Do you know of any kind of headlines, way of explaining this issue, or whether other diseases can be a guide for how these things are likely to evolve and how big of a problem this could be?
It's obviously a hard problem. And I think that there are many threads here. So going back to some of the themes that Ramanan was hitting on, I think that early collaboration and early learning required that global context, right? It was essentially a friendship between Professor Zhang and Eddie Holmes that got us the sequence online. That was this international relationship that allowed us to create the vaccine. So there has to be some level of collaboration at the roots. And it was raging pandemics in the UK and Brazil that allowed us to test the vaccine. You also need these collaborations to learn, let alone to distribute. Can we make the case that we're absolutely certain that sharing doses is in the enlightened self-interest of every country? It's very hard. I mean, but this is a recurring feature in public health. And I think I'm also going to throw this problem to Scott, the way Ram led the way for, but I think that there's the way in which the analogy has been made with weather forecasting. If the weather forecasting says there's going to be a cyclone and you batten down the windows and the cyclone comes, you're very grateful. But if public health gets it right, the outcome is that nothing happens. And so it's sort of tricky to the counterfactual is never quite there for us to see. However, disease eradication is the classic example. Rinderpest is one that Scott already alluded to, but the other is smallpox elimination. And it's estimated, I believe I learned this from Scott, we edited a special issue on this topic, that the United States makes back its investment in smallpox elimination every 26 days. And I think, so, and that is a reasonably simple set of maths to pull together because of the features of smallpox. The world we're in right now for SARS-CoV-2 is tricky, and it's tricky in part because the thing we need to predict is this evolution piece, which is extremely slippery. But we're learning more and more, and the things we're learning are things about waning of immunity. They're things about the context in which variants emerge. So I think that we might narrow in on identifying the degree to which that argument for enlightened self-interest could be made. And I think that the baseline, you know, although there is no strong certainty, there's certainly more cases circulating in the world means more likely that some evil variant emerges again.
Now, one thing I've actually thought quite a bit about is that some of the things that characterize vaccine nationalism, in some sense, are broader issues that are not just about vaccines. So, for example, the access to PPE also turned out to be a problem where, you know, the UK government sent a military airplane to Turkey to pick up masks. And also, for example, the UK government early on in the pandemic actually made a long list of medicines that were no longer to be exported because they could be used maybe as antivirals and so on. So these are all examples of situations where people are kind of hanging on to whatever stocks they have of particular equipment. And this is kind of low grade stuff because, you know, PPE equipment does not take an incredible infrastructure and medical know-how to produce, but it produces some of the same kinds of issues. So I just wonder whether this is just a general lack of coordination or whether there's something very specific to the vaccine.
I wonder if, so didn't Fauci say when people said, are you going to boost the United States or share the doses? Well, we're going to do both. You know, building resilience and capacity into all of the health system aspects is sure, I mean, clearly it won't be, but surely it should be one of the take-home messages of the pandemic. But I know that's a cop-out.
Okay.
You know, it's interesting. If I can just jump in, a little anecdote. I was chatting with D.A. Henderson, who, you know, in a nod to Jessica, was in charge of the smallpox eradication program. So a remarkable man with a remarkable achievement. But I was chatting with him in his office at the DHS during the George W. Bush administration, when the worry was about bioterrorism. And the US had a plan. There was a worry about release of smallpox. So the US had a plan that would produce vaccine, one for every person in the population. And I said to him, what happens if there's an outbreak in Poland? What does the US do? Does it just vaccinate everyone within the United States and, you know, say good luck to Poland? And he said, he was a very clever man. He said, actually, we've worked out that you can dilute those doses and basically do something. I can't remember the exact number, but I think triple the amount of doses you can get from this stockpile. So through the back door, as it were, which is kind of classic Henderson, as I understood him, through the back door, he had already thought about this. And there was that kind of capability. But that anecdote kind of lays it out there that what I call this impulse of self-interest, which is not the only human impulse there is, by the way. So I don't want people to think that, you know, issues of ethics are not critical. They are. But nonetheless, this particular impulse is pretty reliable. But there are ways in which you can, because you realize that, you know, it's also a country that only protects itself when there are 300 million doses. Is also going to be a country that others are not going to remember fondly, right? So this goes back to Ramanan's point about how the U.S. could have played a leadership role here. So I think that there's a shadow of this that's present all the time, and we have to learn how to bring it, I think, more into the light and have you know, structures that really would promote you know, achievement of these more global aims about getting this pandemic under control and preparing for future ones.
So in a very direct sense, the ability of different countries to actually control the pandemic will, of course, influence their ability to manage the economy and to have economic growth and well-being. Is it useful to think of vaccine rollout as just one piece of a broader commitment to helping low and middle income countries that most wealthy countries have already in principle signed up to?
I mean, what is, I don't quite get the gist of that question. Is it, are you saying, is that a humanitarian obligation that rich countries have signed up to? Well, if they have, then I think the modus operandi of the rich countries is we'll first take stuff as much as we need, and after that, if there's anything left over, we'll give it to you. That's really what the plan has been, which maybe works fine with other things, but it works well for malaria drugs because rich countries don't need much by way of malaria drugs, or for tuberculosis medicines. But doesn't work so well when it comes to responding to a crisis where everybody needs some level of protection. And I think the ethical challenges of vaccinating children, aged 12 to 18 in the United States, when there are people above 65 in sub-Saharan Africa who are at far greater risk. I don't know if you know the numbers. Your risk of dying of COVID in the 65 plus age group is literally 1,000 times that of being in the 12 to 18 age group, 1,000 times. And I don't know in what ethical framework you can justify vaccinating a 12-year-old when there's a 65-year-old who needs that vaccine. There's just no explanation for this. So I think that when history is written about this, just as history looks at the smallpox campaign or other things that the United States did in terms of leadership, including on HIV, with a great degree of admiration, the world will look at what has happened with COVID as a absolutely stark failure to lead that was just not just a failure of leadership, it's a failure of ethics and a failure of morality. And the numbers are just too ridiculous. And this was at a time when you couldn't say, oh, but they're somewhere else, we don't know how to deal with them. We know how to roll vaccines out anywhere on the planet. We could have done this. And it should have been done. And I don't mean to I say this for the US because I guess, Jess, Scott and I are all, really based there, but this is really Europe as well. Why didn't Europe actually say we're going to make sure that we're going to get vaccines around the world as a priority before we focus on really anything else? I think this is a sense of, if once I've had my fill, I let someone else eat, but not at the cost of my, eating absolutely as much as I want. And I think that has been, there's no other way to put it. It's been a depressing situation and really one which history will judge these countries very poorly on the basis of.
So if I could move the discussion a little bit in another direction. So Ramanan, you said something early on that I thought was kind of interesting. You said that actually there was not a lack of capacity to produce, but that capacity presumably was just not exploited to the full potential. So do you think, so there from some quarters it's been suggested that really patents was a stumbling block towards greater production. Other people have said, no, it's not a matter of patents, it's a matter of patents plus know-how, and the patents alone would not make a difference. Now, these, of course, are very politically charged issues. Do you have an opinion on this?
No, I think it's patents plus know-how. People who criticize, this is, I think they went after Bill Gates when he said that patents, making those open don't solve the problem. I think most people who talk about this stuff have never actually produced a vaccine in their life or know what kind of regulatory constraints there are. You can't just stand up a vaccine manufacturing plant tomorrow. It just takes years and years. And even if you put every single patent online and free for everyone to use, it doesn't mean that vaccines could have been produced in Africa for another 10 years at least, maybe even longer than that. So, there's a lot of, silliness that's going on as well. But because, people are conflating, theoretical hypotheses from what could have been real. But in the real, was it possible for there to be far greater production of the mRNA vaccines to serve the rest of the world, and I think there could have been. These are not. These are lab-produced vaccines. They are literally, you can do them on a bench top, and that's why they're both a miracle, but really a miracle that weren't used everywhere. And there are excuses to say, oh, but Africa doesn't have the vaccine cold storage for -20 or -80 or whatever it is. That stuff is solvable. I've seen this happen in India where you can put in refrigeration very quickly, or you just line people up in a city, and you fly in the planes, and you have a C-130 transport aircraft with -80-degree refrigeration, and you basically line up everyone and vaccinate them. It could have been done. I think we need to separate the real issues from the not real issues, and I think trying to say that we could make these vaccines everywhere in the world is a bit nonsensical.
Just to chip in on that, I am puzzled by why it's been so hard to ramp up production, but I think there are actually serious technical challenges alongside all the regulatory challenges. One of the themes that's come up, again in a nod to what Scott was saying about smallpox, is that people have suggested that you could use smaller doses. You should be trialing use of smaller doses in order to stretch the doses that we have further. Of course, the degree to which that's important will depend on the scale of global production of doses and what trajectory we're on. And it's also somewhat problematic if the way or at least one could see that this might be perceived as rather problematic if you're going to be sending your kind of half doses to lower middle income countries, having given your civilians, the full doses. That also seems might not be very encouraging.
Could I just jump in on this point? So I agree with what Ramanan said earlier, that it's really extraordinary that we have these vaccines at all. So it's actually a great problem to have about distribution, because you've got something to distribute. So I totally agree with that. But I have been worried, and I don't know the answer to this, but this is very much connecting with Jessica's point. I have been wondering, is it the case that we've done the best we could, or is it the case that there was a bias in the R&D efforts towards vaccines that would be of particular value in richer countries as opposed to poorer countries? I mean, am I wrong about that? I have no idea. So I'm just throwing this out here as a question for people who know better. Am I wrong about this? Or maybe if you had a vaccine, the efficacy wasn't as good, but very easy to distribute, very easy to produce. Jessica's example of the dosage would just be, one dimension of that. There could be others. Are we sure that the direction of the development and the R&D was right for the world, as it was clearly right for richer countries, but was it right for the world? I just don't know the answer to that, but I'm curious.
Well, in the UK, they went somewhere in that, they didn't dilute the doses, but what they did do is they stretched out the period between them. So that's kind of an ingenious way of trying to make them last longer. Could I just remind the audience that you're more than welcome to put questions to the panelists, if you'd like to do so, you can do so in the chat. So one thing that I found startling during the last few months for my own research, I thought it was interesting to look at what is the production capacity and what is in different countries or in different companies, and what are the stockpiles of different governments of vaccines. And it's been almost impossible to find any reliable data. What I have found, though, are situations where government officials have actually encouraged their own health services not to publicize how many doses they had, presumably because they didn't want to invite pressure on themselves to share these share these stockpiles with more needy countries.
Logging out and coming back in again. Right.
What's your take on the lack of transparency on both stockpiles and production capacity?
I can address first Scott's earlier question, which is that the paradox was that, this is about the vaccines which are easy to make but difficult to distribute, which would be the mRNA vaccines. And in some sense, the CHAD, the chimpanzee adenovirus vaccine, was really the middle path in a sense. It was relatively easy to scale up relative to, for instance, the inactivated virus, which is what the Chinese use and what the Bharat Biotech vaccine uses. Those have been very challenging to scale up. But these were not difficult to distribute. They could go through existing cold chains. So in a sense, the AstraZeneca vaccine was really that. And I think, as Flavio said, this playing around with how frequently or how much time it takes between doses was really the way in which this partial dosing question was really addressed, because there's different ways to skin that cat, and this is certainly one. But Flavio, to your other point, I think that I don't know a lot about, I don't track vaccine availability in terms of where the data are really available. But keep in mind that, of course, we do know some things. We do know that large quantities of vaccines have been trashed in the United States because they expired. And we don't need to know a lot about vaccine availability to say, if you're trashing millions of doses, that could have saved someone's life. And even assuming that one in a 10,000 of these save a life, that's a lot of lives that you lost by not deploying those vaccines. And I think that it's very clear that just like international cooperation was really what worked for developing the vaccines, international cooperation is really what would have worked for delivering the vaccines as well. But unfortunately, at that point, that mechanism didn't really work out.
Yeah, so there are examples where they've solved that problem. Israel and South Korea did a swap where South Korea got vaccines that were about to expire in promise of a future, quid pro quo in terms of vaccines. Now, one thing that has also been the case, of course, as I alluded to earlier, that the European Medicines Agency didn't want to accept AstraZeneca vaccines that were produced in India. But more generally, there are lots of vaccines out there that have not been, given the go-ahead by, for example, the European Union. For example, the Sputnik vaccine or the different Chinese vaccines, which have nonetheless proved quite effective, at least the Sputnik one, and been been used in many countries. Should we see this as a instance of regulatory failure, that they haven't moved fast enough to maybe give emergency authorization for these kinds of medicines? Or are we right in that we really need to go through all the hoops before we want to give the go-ahead to use vaccines that might not be as effective as the ones from, say, Pfizer or AstraZeneca?
Jess, you want to take that?
I think it's a fairly nerve-wracking space, right? Because it's so important that people have trust in vaccines, and it's so still true that we don't have, we have correlates of protection, but we don't really know how they translate over time, et cetera, et cetera. Of course, the other side, and I think Scott and Ram probably know much more about this than I do, is that by having Sputnik, by sharing the Chinese Sinovac, for example, is used widely in Thailand. So you have this dose diplomacy and influence that's shaking out but then sort of oddly blocking travel of Thais to the UK. So I think that many people were anxious about how fast the vaccines have been authorized, and there are good cases that can be made as to why this was so particularly fast relative to all historical vaccines. The scale of the trials, the number of volunteers, the fact that we had a raging pandemic that allowed us to evaluate efficacy, all of these things are incredibly unusual. But it still caused anxiety. And of course, Scott mentioned this, vaccine hesitancy is an absolute challenge in this space and in the world that we also have to keep in mind.
I'll just add to that, Flavio, to say that, our rules for how we approve vaccines are all peacetime rules. They care about ethics, they care about human subjects protection. Typically, the bar for a new vaccine that comes in is that it has to be at least as good as the existing vaccine, all of which are good rules to follow in peacetime. It's hard to suddenly switch those rules to when you're in wartime, where these other considerations come into place, where you say it's fine if I don't have a 98% efficacious vaccine. I'll take the 70% one because I can protect a lot more people because I have production production scale up issues. Our systems are not geared towards that sort of thing. Our systems are geared very much to, in the normal course of things, those rules make a lot of sense, because why would you ethically give someone a 70% efficacious vaccine when there's a 98% efficacious vaccine that's around? And typically institutions are built around these kinds of stodgy rules because that's what makes them strong and without having exceptions being made all the time. But unfortunately, what we learn is that during a fast-moving pandemic, then it's hard to just turn and change these rules around. And I think obviously it comes at the cost of lots of lives, but that's really the challenge we're facing. And the other part is also that this is a much more general point, which is that the complexity of issues that exist in things like COVID and will undoubtedly face us with climate change are at a level that is simply beyond the capability of not just the average person on the street, they're beyond the capability of most policymakers in most countries. And I think they revert to a very reptilian way of thinking about things when these are simply questions. I mean, I don't say that in a negative way. I just think that it's hard to get them to understand things which are really, really difficult, scientific questions and issues of trade-off and things of that nature. And so we do have a problem. I mean, unfortunately, our collective understanding of these problems requires a collective level of scientific understanding, but we don't elect politicians based on scientific understanding. And in fact, most of them, and I'm not saying for any particular country, I think across the world, they are simply not equipped to be able to address the kind of complex trade-off issues that we're talking about in order to be able to make the changes and say, listen, this rule doesn't make sense for right now. We need to go into emergency use authorization and we need to relax these. Maybe we'll take the opportunity to learn this better for the next time around. And that's what we should focus on, to realize that the current institutions, the current rules work well in peacetime. They don't work well in wartime.
Just we have a few minutes left. I just wonder whether I could ask you for your take on vaccine mandates and that sort of policies. These are, of course, very tricky questions that most societies are dealing with right now, and they don't maybe necessarily have an international angle to them. Vaccine mandates, for or against? What are the trade-offs? If I could ask each of you.
I guess I haven't spoken for a while, so it's my turn. Or maybe this is one of those questions that Ram and Jessica don't want to answer. No, I was kidding. Yeah, so I'm very much in favor personally of the vaccine mandate. My own university requires that everyone be vaccinated. I gather that the vaccination rate is something like 99.9%. Yeah, as you know, certain people, even if they get vaccinated, the vaccine won't necessarily take, and there is some other complications, but that's worked really well. We basically had virtually zero transmission within the university, and we're embedded within New York City, for God's sake. So it's pretty impressive what's been achieved. It's interesting. This goes back to Ram's point about war and peacetime. Actually, I thought what was so impressive about the rollout was that because we were in the midst of a crisis, a lot of people were very happy to volunteer. And people like me were very keen to be vaccinated as quickly as possible for a lot of reasons. It wasn't just my personal health. So I think that what has to happen is once you've gotten those people, you have to then appeal to the next group, as it were, and work down from there until you get to Jessica's effective reproductive number 1, where transmission has ceased to be a concern for some population. So I think in many ways, what we're learning today is that we don't need a single policy for dealing with people. We need a multiple policies because they're different types of people and they have different types of beliefs. I think this is really important. You obviously see that in subpopulations like the Orthodox Jewish population in New York, among some Black populations, definitely among Republican Trump supporters. So we've got this, Ram was talking about science, but what we're seeing now is that people's belief correlates with their ideology. And it actually doesn't have much to do with their education. I've had bizarre conversations with MDs about climate change. It's been quite shocking. And there's quite a bit of evidence for this. So this actually changes, I think, to some extent, how we see public policy. And that we're not talking about just a policy for a population, which is how I think we normally have looked at this. But also, we're going to have different kinds of, we have a polarized population. You have to have different kinds of policies for different kinds of populations. Again, in a way, this isn't completely new. Vaccine hesitancy has often had subpopulations, promoting it. But I do feel like that's one of the big challenges. And the vaccine mandate, I think, particularly for people who are working in public services, this is how it's being used in New York City. I think that's appropriate. They're serving a public purpose. I think we are absolutely right to require it. But still, to get to the kind of herd immunity that Jessica mentioned before, I mean, gosh, we really have to reach out and get the most difficult people, even trying to get up to only 70, 80% only. It's difficult. Getting those last groups is going to be very difficult. And I think we're just still learning about how we can do that.
Jessica, would you add something to that?
So we're at the boundaries of my field in some sense, but I think I completely agree with Scott. I am certainly in favor of mandates for anyone who is public facing, public service. Teachers, doctors, nurses surely should be vaccinated, who might put people at risk. How we manage that in the face of hesitancy and how we don't worsen things. I mean, it does also seem that people are very vocal about, I'll quit if there's a mandate, and then they all get vaccinated because it's just easier. so how you walk that line I just don't know. But I think it's something we should be doing vast amounts of research on and better understanding.
I think one of the things that governments can also do is to give private businesses legal cover, so that if they, for example, refuse service to people who are not vaccinated, that they are protected and not, get lawsuits on themselves. And I think there are now a growing list of examples of private businesses, like, for example, Qantas, that I don't think you can fly with them unless you show a vaccine certificate and so on. So I think even if there is not vaccine mandates, I think civil society and businesses will slowly move in that direction and just make life very, very complicated for people who opt out of vaccination, of course. Ramanan, do you have any famous last words on that topic?
No, I mean, no words famous or otherwise. And on the vaccine mandate, I sort of think of this as like seatbelt rules. We are looking for exceptions for some people for some reason or the other. But, seatbelts are in place and mandated to protect just the individual, forget about other people. And people don't have a problem with this. I just don't know why we are pandering to people's unwillingness to do the right thing and making up all sorts of excuses to say, oh, but if it's a mandate, then I won't really do it. This is just too bad. This is a global pandemic, and I think people will have to figure out how to get in line. If there were a war, and this is no different than a war, there are millions of people dying, and I think that's the way in which to really see it. So I'm all in favor of mandates, even though there's all the excuses that can be made about how you don't want to impinge on people's personal liberties and so forth. The state of Mississippi has no problem, removing non-medical exemptions for vaccines, and that's a pretty conservative state. If Mississippi and West Virginia can do it, surely the rest of the world can do it.
No, I think that's right. I don't think anybody during the Blitz would insist on their private liberty to switch on lights in the middle of the night.
Exactly.
Viewed by bombers. Very good. I think we're at the end of the road here for this event. I would like to take this opportunity to thank our three guests, and also to thank the team at the Bennett Institute for impeccable backup and support and planning. I would like to encourage you all to follow the other events of the Bennett Institute. There's a website which has been provided here, the link. This discussion will also be made available through YouTube later on. And so if you found it useful, please do share with others. And that's all I have for you today. So thank you very much again, and be safe. And I hope to see you all in person sooner rather than later. Thank you.